Thank you, Adam, and good evening, everybody. As Adam said, I'm Peter Fairley. I'm the Director for Strategy and Health Integration at Essex County Council. I'm just going to say a few words this evening about health inequality in Essex, what it is and why it matters, but also how technology can play a role in helping to mitigate some of those inequalities. But I'm also going to finish by concluding of some of the challenges as well that we need to consider, particularly around digital inequality and exclusion. So what are we aiming to achieve in Essex? Our vision in the Essex Health and Wellbeing Strategy is an Essex where everyone can live well together. We want to see reduced health inequalities, and we want to see people enjoying the best health outcomes that they can. Sadly, though, that is not always the case. We have huge variations in life expectancy, which can vary by easily over a decade between the most deprived parts of Essex and the most affluent. We saw through COVID how the pandemic adversely impacted on some groups and some communities and some ethnicities more than others. So we can see that inequality in Essex leads to differences in life outcomes, differences in life expectancy, and some people suffer for longer with avoidable health illnesses. So tackling health inequality is a key public health challenge for Essex County Council and all of our partners. This is a diagram that shows part of the impact of deprivation. So these are what's defined as left behind areas. A left behind area scores badly in terms of they're in the 10% most deprived wards in the country. And they also score low in terms of their community needs. So they have less community assets, less voluntary community sector assets, less involvement in the community, and also less access to services. And in Essex, we've got a number of left behind areas. Now, there's a lot on here, but I think the key thing to show is that across 20 of 21 major health conditions, in the left behind areas where there's high deprivation and low community assets, they've got much higher scores or worse scores on 20 of those 21 conditions than other deprived areas and than the England average. So you can see, just to pick the top few lines, higher rates of high blood pressure, higher rates of obesity, higher rates of depression, higher rates of diabetes, and you can go on through that list. So community assets and deprivation make a huge difference to the health outcomes that are experienced by people, and tackling that inequality is a huge public health challenge. We can see also that deprivation links directly to demand for health and social care. These graphs here, the graph on the right certainly is showing social care. So to pick the graph on the left first, we can see that over the last decade or so, since 2007, the proportion of the Essex population living in the 20% most deprived areas has more than doubled, from about 4.5% of the population in 2007 to about 9%, just under, by 2015 and 19. The graph on the right is showing for the 3 financial years there, the correlation between indices of deprivation and the percentage of new demand for adult social care. And you can see the direct correlation between deprivation, the most deprived areas on the left there contributing the highest volume of new demand for adult social care. And then as you go across the graph, as an area becomes less deprived, there is indeed less demand for adult social care. So we can see that deprivation does have an impact on demand, and that obviously comes with financial costs, but it also means that people in those areas of deprivation, as we've already alluded to, are living with multiple complex needs that's hindering their ability to work, hindering their ability to enjoy quality of life, and too often leading to lower life expectancy. We also know that addressing health inequalities is not just a matter for public health or for health services. So there's a model called the wider determinants of health, and what we're just trying to show here is some of the contributions that impact on health outcomes. So we can see that the physical environment at the bottom there influences about 10% of health outcomes. Social and economic factors are the big one. So education, employment, income, family support, all of those contribute to around about 40% of health outcomes. Clinical care, so access to primary care services, to acute services, and the quality of that care actually only contribute to an estimated about 20% of health outcomes. And then 30% sits around the behaviors of individuals themselves and communities. So whether people are using tobacco, or whether they're exercising or not, whether they've got poor diet, drug and alcohol use, etc. So you can see that tackling the wider determinants of health is critical, and that you need to take a whole system approach. So what about digital and technology? Well, in terms of the benefits, we believe that digital and technology can make a really important contribution. And I should say at the outset, we believe that we're starting at a pretty low base in the health and care sector in terms of its application of digital and technology. Great strides forward during the pandemic, really rapid strides forward during the pandemic, but there's no doubt there's more further that we can go to catch up with how digital and technology is playing in other sectors. But some of the things it can do, it can aid smart and healthy living. For example, my phone, my watch can remind me that I haven't stood up in a while and it would be a good idea to go out and exercise. We can measure blood pressure, etc. Technology can increase confidence and independence, both at home and in the community. So there are adults, for example, with learning disabilities who may not feel comfortable going out on their own, but actually with the right technology support and the knowledge that they can quite easily contact friends and carers, it can raise their confidence. We can see that it can reduce demand for more costly care packages. We've certainly been doing work in adult social care to find ways where the technology can complement somebody's care, and as a result actually help to reduce some of the need for hands-on face-to-face care. And it has the ability to prevent and reduce delay the onset of need. An example from the pandemic in terms of what we did at Essex County Council, very early on, around about April 2020, we realised that because of the restrictions, people were essentially going to be locked up in their own homes. They wouldn't be able to have visits from families or friends if they weren't part of their bubbles, and they might not be able to have face-to-face contact even from care providers. And we knew that we needed to try and address that. So we took an urgent decision. We procured 2,000 tablet care phones, which we then rolled out to vulnerable people in the community. And that was to enable those people at the touch of a button to connect with their care provider, to connect with their friends and family, so that they could have that kind of contact. So examples like George, 90 years old, because of the pandemic, he was unable to visit his day centre. He became moody and withdrawn. He'd lost his social contacts, but through the tablet, we were able to connect him with people who he used to go and visit in the day centre, so we could connect him to his friends. We were able to connect him to exercise sessions twice a week, which he was able to do remotely through the tablet, improving his mobility, protecting his strength, and making him happier as a result. We also saw through the tablet, we got access to data that we would never ordinarily have been able to access. So you can see on the right there, when we then looked at the data in terms of where people were making phone calls and making contacts, 16 American states in the United States, people in Essex were contacting regularly. Calls in South Africa, Canada, Australia, obviously Europe and the UK were the main. So what the tablets were doing was supporting people. On Christmas Day, for example, I think there was something like 50,000 minutes of calls where people were being connected. So a really good example of how technology could support people. And just one coda on that. Something we've been really pleased about at the end of this, obviously the original, since the lifting of the restrictions, the original remit and purpose of the decision has kind of fallen away somewhat, but we've done two things. For those people that wanted to keep the devices, we've gifted them to them so that they can keep them. And for those where the devices have been returned to us, we've then been able to offer those and gift them to community groups, voluntary community sector groups, tackling digital exclusion, supporting volunteers, such as Hearing Help Essex, to go out and do their work, and they can capture their records on the tablet. They can call in as well, virtually, via the tablet to their customers. So making absolute best use out of the technology. Another thing that the County Council's also done, has been pleased to do, is we commissioned a new county-wide care technology service, and that's gone live on the 1st of July of this year. And that is around making a better use of bundles of technology in ways that can support individuals. So I'm not going to run through everything, but that might vary from wearable technologies such as glasses, the more traditional type sensors that can detect when somebody's fallen, to Alexa devices, tablets, etc. So the different technology will vary by person and vary by need, but trying to make sure that we're making the best use of the different technologies that are out there. And that offer will continue to grow over time, because we're being clear to the successful provider that we want to be able to see, in 5 years' time, we're making the best use of the technology of 5 years' time, rather than continuing to use the technology of 2021. And again, that technology will give us new insights. So there's a lot on here, but essentially what this is trying to say is that through the technology, we will be able to collect data and information, which will be able to, on the left-hand side, at the top left there, it will generate insights in terms of people's health conditions, their mobility, but also it will enable us to, over time, develop essentially a catalogue of which technologies are making the most impact on certain conditions, so that when a social worker is assessing me, let's say I present myself to a social worker will say, well, we've then looked through our kind of catalogue of digital, and we know that having worked with 1,000 people of similar kind of conditions to you, that actually technology A has had this impact on you, technology B has had that impact. And of course, that evidence will continually iterate as we go through. So making much better use of the data and insights that we can glean from technology in a way that you can often struggle to quantify from simply face-to-face. However, there is also a challenge, and this is the slide that I'm going to leave us with. Digital can play a huge and positive role. Hopefully we've set that out, and hopefully that can help address some of those inequalities and prevent need. But we know that not everybody has access to digital. Again, going back to those areas of deprivation, it is more likely that access to digital and the latest technologies will be less prevalent in the most deprived areas, because they've got less disposable income. We know that with age, over 65s and women are less likely to use the internet. We know that people with a disability in some ethnic groups are less likely to be using the internet. And we know that there are some links with lower levels of education as well. So one of the challenges, I think, for us all to think about is not only how can technology play a role in kind of mitigating and preventing some of the health issues that we've raised, but how can we, as organisations across the public, private and voluntary sectors, help to address digital exclusion? Because if we don't do that, what will happen is the inequality will widen and widen and widen, where those with the most wealth and assets, who are least likely actually to have the health issues, they will be able to access the technology which will make them support them to live more independently and healthier, and we won't be benefiting those who are excluded. So a big challenge for us all to think about. Hopefully this has given you some food for thought in terms of why health inequalities is such a big issue, and also how technology and digital can play a role in addressing it. Thank you very much.